let's first of all talk about polyhydramnios, right? Now, the incidence of polyhydramnios is roughly about 1 to 2% in singleton pregnancies, right? Now, polyhydramnios based on the AFI measurement or the SDP measurement is further classified as mild, moderate and severe. So, you have mild when it is about 25 to 30 centimeter, then 30 to 35 and then more than 35. So, I roughly remember the ranges, right? And single deepest pocket measurements are also described here, 8 to 10, more than 10 to 12 and then more than 12. So, these are what you need to remember is that you have a categorization as mild, moderate and severe hydramnios also. Now, most of the time in mild cases, it is important to remember that roughly in about 2/3 of these cases, okay, one will not be able to find any explanation. So, most of these cases are going to be idiopathic and benign, right? And yes, when we have moderate to severe polyhydramnios, particularly when we have severe polyhydramnios, we are more likely to find a cause, right? So, talking a little bit about this idiopathic polyhydramnios, it is essentially a diagnosis of exclusion only. First, we exclude other factors, but is there any possible explanation that could be there? Idiopathic polyhydramnios may be a consequence of impaired prolactin regulation of amniotic fluid, right? So, we discussed this briefly when talking about the decidual prolactin also, right? So, this prolactin that is found in the amniotic fluid, it comes from the decidua, right? So, decidual prolactin is the source of amniotic fluid prolactin or prolactin in the amniotic fluid, right? Now, look at it. Let's read what the Spiroff's endocrinology textbook has to say about it. So, there is a role suggested for prolactin here. Prolactin in amniotic fluid would protect the fetus from dehydration by control of salt and water across the amnion. Prolactin reduces the permeability of human amnion in the fetal to maternal direction. So, yes, we said that the amniotic fluid is hypoosmolar and then the maternal plasma is the osmolality is higher. So, fluid could always travel from the amniotic fluid side to the maternal plasma side by that logic, but it doesn't happen. I mean, if you look at the regulation bit also, we talked about how there could be transmembranous across amnion, across the amnion and chorion, across amniotic membrane, there could be resorption of amniotic fluid volume, but that is very minimal, right? So, yes, maybe this decidual prolactin has got a role to play because it reduces the permeability of the human amnion. So, there is this amnion, let's say, right? This is the amniotic fluid towards the fetal side. This is the decidua. This is the maternal side. Basically, this is amniochorion, right? The fetal membranes are there. So, fluid could move in, right? But this is very minimal. This is limited. This is reduced permeability of amnion in the fetal to maternal direction, and maybe prolactin has a role to play there by reducing this permeability, right? Now, look what else they are mentioning. They are saying that decidual and amniotic fluid prolactin levels, they are also found to be lower in hypertensive pregnancies and in patients with polyhydramnios. So, what is important to note here is that it's not much of a clinical relevance because we're not really testing for amniotic fluid prolactin levels anyways, but this is important for theoretical reasons, okay? Now, moving on, what are the causes of polyhydramnios? So, like I told you, idiopathic is seen in the majority of cases, right? If you have multiple pregnancy, then it is associated with polyhydramnios also. Now, see, for when they have a multiple pregnancy, each fetus's amniotic fluid volume in the form of SDP will be separately measured, right? So, when you have multiple pregnancy, the incidence of polyhydramnios in multiple pregnancy is roughly around 18% in both monochorionic as well as dichorionic type of twin pregnancies. Then congenital anomalies could cause polyhydramnios, and it is roughly seen that about 15 to roughly about 15% cases will have congenital anomalies when there is polyhydramnios. Maternal diabetes is roughly seen in about 15 to 20% cases of polyhydramnios. Then fetal hydrops, and fetal hydrops could happen because of any of the underlying causes of fetal hydrops like cardiovascular system anomalies or aneuploidies or fetal hemolysis or fetal anemia. So this becomes a separate discussion altogether, but remember that fetal hydrops can also be a cause of polyhydramnios. Rh affected fetus, again fetal hemolysis, fetal anemia can explain polyhydramnios here. It can be seen in the setting of fetal infections, particularly syphilis, toxoplasmosis and parvovirus. And then we have a rare kind of a tumor arising from the placenta, which is a chorioangioma. Now, if you want to make sense of why polyhydramnios occurs in these situations, then most of the times the explanation can be polyuria in the fetus, excessive urine production by the fetus, right? And you can have maternal hyperglycemia contributing to this, right? So in the setting of diabetes in pregnancy, diabetes mellitus in the setting of GDM, when there is maternal hyperglycemia, then obviously it will be causing fetal hyperglycemia as well. And it will be leading to osmotic diuresis, polyuria in the fetus, right? And then again there can be other situations where there is hyperdynamic circulation in the fetus, hyperdynamic circulation in the fetus, right? What basically it means is high output states, high cardiac output states in the fetus because of whatever be the underlying reason, that will also lead to polyuria in the fetus or increased urine production by the fetus. So certain examples could be very well understood. Now with this context, you can remember the causes, like for instance, if there is fetal anemia, whatever be the underlying reason for fetal anemia, right? So no wonder when we talk about fetal infection, parvovirus B19 infection of the fetus, because it causes fetal anemia, it is very likely associated with polyhydramnios as well. So fetal anemia becomes one in the setting of twin-to-twin transfusion syndrome, where one twin is bleeding into the other twin, when you have this fetal anemia happening in one twin. So in that setting also, we can have high cardiac output states. And we tend to see a polyhydramnios in the recipient twin, because it is the recipient twin which has a high cardiac output. We are going to talk about this in detail when we talk about twin pregnancy. But remember, when there are high cardiac output states in the fetal circulation, it can lead to polyuria by the fetus and it can lead to polyhydramnios. So other examples could be fetal thyrotoxicosis, right? Sacrococcygeal teratoma. Okay, sacral coccygeal teratoma is a fetal tumor. Okay, now tumor takes a lot of blood supply. Okay, and then there is this fetus heart which is pumping for all that extra requirement of the tumor as well. Again, a high cardiac output state. Or in situations when there is a placental chorioangioma, okay, that is also creating a fetal high cardiac output state as well. And then we can have cardiovascular system anomalies where there is high cardiac output state in the fetus. Example could be the Epstein anomaly or tetralogy of Fallot could be there, right? So understand the mechanism here, right? So much of it can be explained by excessive fetal urine production.